Good afternoon, or good morning for those of you here on the West Coast as well. I'm Akil Hunt, Director of Patient Empowerment at Retrophin. We'd like to welcome you to today's talk. Retrophin is proud to be continuing our partnership with Black Health Matters and are excited to be the presenting sponsor for this event. Both Retrophin and Black Health Matters are committed to empowering patients so that they can make more informed decisions about their personal care. In regards to FSGS, we're hoping that events and talks like this one will help drive more awareness about this condition. As those you may know, African Americans are approximately 4 times the risk of FSGS compared to European Americans. Black and African Americans suffer from kidney failure at a significantly higher rate than Caucasians, more than 3 times higher. Yet a lot of us don't know about that risk. African Americans constitute more than 35% of all patients in the US receiving dialysis for kidney failure, but only represent 13.2% of the overall population. That's why we think it's really important to have open and direct conversations about the risks of some of these kidney conditions, and particularly around the risks of FSGS. Today's conversation will be led by Dr. Rasheed Gbadegesin. Dr. Gbadegesin is a professor of pediatrics, Division of Nephrology at Duke University in Durham, North Carolina. He is an investigator at the Duke Molecular Physiology Institute, and he is also the co-director of the Duke CTSA KL2 program and the program director of the Duke Pediatric Research Scholar Program. In the last 10 years, Dr. Gbadegesin and his collaborators have identified at least 5 novel genetic causes of steroid-resistant nephrotic syndrome, or FSGS, and other kidney diseases. I'd like to welcome Dr. Gbadegesin for taking the time out today, and I'll turn it over to him. Doctor?
Thank you so much, Akil, for that generous introduction. I cannot think of a better time considering what we are all going through in our country in giving this talk. And also we need to consider the effect of the COVID pandemic on what I describe as the global village. So this talk is timely and I'm happy to be here. So we're going to be talking about the kidney condition called nephrotic syndrome today. So let's just start from the basics and where are our kidneys? So usually what I tell my patient is to stand akimbo and actually hold their flanks. When they're holding their flanks that way, they're actually holding on to their kidneys. And this is what this figure is showing. So what does the kidney do? So the major function of the kidney is to regulate water and salt in our body and also to remove waste products. When the kidney cannot perform this function, what happens is that we have retention of waste product and water in our body, and because of that, we have elevated blood pressure. The kidney also has some other important function. For example, it produces an hormone that actually helps us to make red blood cells, and it also regulates growth in children. The kidney is also vital and is very important in maintaining bone health. I look at the kidney like a big waterworks. It processes about 120 to 150 quarts of body fluid and blood every day and produces about 1 to 2 quarts of urine. And this urine are made up of waste and extra fluid. When the kidney cannot do this, we retain waste product, we retain water, and we become sick. So how much of kidney disease do we have in the general population, and how much do we have among people of color? So like I said, chronic kidney disease occurs when kidneys are no longer able to clean toxins and waste product from the blood and perform their functions to full capacity. There are at least 37 million people in the United States with chronic kidney disease. Putting it in perspective, that is the equivalent of everybody living in the great state of California having kidney disease. So the problem is enormous. In addition, there is obvious disparity in the prevalence of chronic kidney disease in different populations. We know that we people of color are actually more affected. And the reason for this is multifactorial. There are some genetic factors that we're going to talk about later. And also, more importantly, whether we want to accept it or not, one of the big factors that is contributing to this is disparity in access to healthcare. This is very important, and we need to bring this, anytime we have the opportunity, we need to bring this to the attention of the policymakers. So what sort of numbers are we talking about? So we know that people of color are responsible for 13% of the US population, yet 32% of kidney failure in the whole country is actually in this population. So you are looking at something close to 3 to 4 folds, okay? African Americans are also 4 times more likely to develop kidney failure than Caucasians. So I will briefly describe a condition called nephrotic syndrome now. So what is nephrotic syndrome? It is the name for a collection of symptoms that indicates kidney damage. So the way in which I look at the kidney is I look at the kidney as collection of coffee filters. So we all know that if there is damage to our coffee filter, some of the coffee beans can leak into the urine, and when that happens, our coffee will not be smooth again. That's exactly the same thing that happened in the kidney when the filters are damaged. So essentially what happens is that we'll start leaking protein into the urine, we leak blood into the urine, water will move from the pipes within our body and accumulate in the tissue, and that's actually what leads to swelling. The causes of nephrotic syndrome is actually not known in most cases, but most of the time it's likely due to interaction between our genetic makeup and the unique environment that we are living in. For example, exposure to infections, air pollution, what we eat, among others. There are many causes of nephrotic syndrome, but all I can tell you is that as of today, in majority of cases, more than 80% of cases, we do not know the cause. And this is the reason why it is important to continue to do research. Blood tests can point towards disease that cause nephrotic syndrome. However, the most important test to make a diagnosis of nephrotic syndrome is through a kidney biopsy. One of the diseases that causes nephrotic syndrome is actually what we call focal segmental glomerulosclerosis. And we know that we people of color are actually disparately more affected with this condition. And I'm going to spend some time on this. So what is FSGS? It's actually a big word that we can break down. So the F stands for focal. That means some of the filters are actually damaged. Segmental means sections of the filters are damaged. And glomerular actually stands for the kidney filter unit. Sclerosis means scarring over time. So FSGS is a disorder that affects the kidney's filter unit. They stop filtering the blood properly. And like I said earlier on, because of that, protein spills into the urine, and it disproportionately affects we people of color, especially those from West Africa and the Caribbeans. So this is the way to look at the filter unit of the kidney. So we can look at it as a 3-layer filter where you have one part of the filter facing the blood and sitting on a base, what we call the basement membrane, and then another part facing the urine and sitting on the opposite side of the basement membrane. Okay, of this, the one that is facing the urine, these cells are actually called podocytes. And what we have known in the last 10 to 20 years is that these cells are very, very important in why people develop FSGS and related kidney condition. If you look at the podocyte under high resolution microscope, it actually looks like an octopus. So when you have injury to the octopus, FSGS and nephrotic syndrome develop. Okay. So when the podocyte or the octopus are damaged, basically the barrier between blood and urine becomes weak, and this allows large molecules like protein to escape into the urine. And that's what this figure is illustrating. So this is the healthy and nice podocyte. That's the blood interface. That's the basement membrane. And these are the nice, healthy podocytes. When these podocytes are damaged, they become flattened, they lose their processes, and actually they become highly motile. And that actually disrupts this barrier. And because of that, you actually have protein escaping into the urine. So when we look at the filters under the microscope, this is the kind of thing that we'll see. So we see the blood flowing in, and these are the capillaries that actually makes up the filter. And what these capillaries will do when blood is flowing through is that it will remove excess water from our body, it will remove waste products and dump all this in the urinary space, and then we make the urine and then pass the urine. And then the purified blood is actually circulated back into the body. So what happened when the filters are not working properly? So when the filters are not working properly, when you have scarring of some part of the kidney, what is shown as whitish pink here, this part will not be able to filter the blood very well. So when you look at the kidney under the microscope, this area will actually appear pink. This is one of the few instances in life when too much pink is not good. Otherwise, pink is actually a beautiful color. I love it a lot. So what are the symptoms of FSGS? So the first thing that you will notice is that the person will be leaking protein in the urine, and how that will manifest is that the person will start passing foamy urine. In fact, I've seen a patient in the clinic before when the child actually started complaining to the mom that she's passing foamy urine. Mom did not attach much importance to this, and she was actually making fun of telling her, go and pass bubbles. Okay, so when we have protein leaking in the urine, ultimately what happens is that the protein level in the blood will be low, and this will actually lead to swelling in the body. The swelling usually starts from the eyes before involving other parts of the body. Now, because we are leaking protein, albumin level will be low. The body will try to compensate for this, but in the process of compensating for it, the liver will actually produce protein that leads to us holding on to cholesterol. So if you have nephrotic syndrome or FSGS, and they tell you that your cholesterol level is high, it's not because you are not eating well, it's actually part of the condition. Of course, because the kidney is not working very well, what we use to monitor kidney function is creatinine, and the creatinine number will be high. Because the body is holding on to salt and water, blood pressure will be high. So how is FSGS diagnosed? So I like to start simple. The easiest way to diagnose FSGS when you notice all these symptoms is to get to your doctor and do a simple urine test. It takes only a couple of minutes. They will just dip the urine and they will be able to tell you whether you have protein in your urine or not. And then they can do additional blood test, which is going to show low protein in the blood and high creatinine in the blood. But the gold standard for diagnosing FSGS is actually by doing a kidney biopsy. So who does FSGS affect? This is very, very important to know. We know that FSGS is now the most common glomerular cause of end-stage kidney disease in the United States. When you talk to people that crunch number and the policymakers, they will tell you that it affects 8 in a million adults and 1 in a million children in this country, and that it's not as common as diabetes or heart disease. But the way in which I look at it as a physician, looking after the unfortunate people that has this condition, is that single child in the family that is presenting to me in the clinic, as far as I'm concerned, the incidence in that family is 100%. And that's the way in which I look at it. And that's the way in which all of us should look at it. So FSGS accounts for 20% of nephrotic syndrome in children and 40% of nephrotic syndrome in adults. Like I've said it earlier on, it's more common in people of African ancestry. There are some genetic basis for this, which we are going to get to later. Surprisingly, FSGS cases are actually rising compared with other types of disease affecting the kidney filters. The reason for this is not known, but people are actually looking at it. Yeah. However, we should know that some famous people also have FSGS. and they are not allowing it to define who they are. Examples are Alonzo Mourning, former Miami Heat superstar, and Sean Elliott of Spurs. These folks and other people are great advocates for people living with focal segmental glomerulosclerosis, or FSGS. They are drawing the attention of the policymakers, they are drawing the attention of researchers to it, and they are doing their best to make sure that we keep it in focus and we ultimately find an enduring cure for this condition. So there are different types of FSGS. The most common one is the one that we call idiopathic FSGS. When you go to a doctor and they tell you idiopathic, essentially what they are saying is that we simply do not know how you got this condition. And unfortunately, in 80% of cases of FSGS, and that's actually the label that we give. And this is the reason why ongoing research is vital. When you know the cause of a condition, it's a lot easier to actually find cure. And this is why we should all participate in research, not just research that is doing drug trials, research that are looking into finding the causes and how people develop FSGS. This is what I spend my daytime doing. A few cases of nephrotic syndrome are actually due to genetic defects. We are going to talk a little bit about this later on. We also have secondary FSGS. So some infection, for example, hepatitis B and hepatitis C infection can cause FSGS. And in the last 4 to 5 months, and since the beginning of this pandemic, we've also learned that COVID can also cause some form of FSGS that is called collapsing FSGS. Exposure to medications and some heavy metals can also cause FSGS. So exposure to lead, medication called interferon can cause secondary FSGS. Some people with cancer may actually present with nephrotic syndrome first as a manifestation of their cancer. I've seen a patient before that presented to me with nephrotic syndrome. I was trying to figure out why this person developed nephrotic syndrome, and in the process of doing it, what I actually found out was that what this person has is actually lymphoma. Okay, process that actually alter the structure or function of the kidney can also predispose to FSGS. For example, if somebody has cancer of the kidney and then they remove one kidney, what the other kidney we try to do would be to work hard to compensate for the absent kidney. In the process of doing that, that can actually lead to progressive scarring of the kidney, leading to FSGS. Some other things that we do, for example, we know that people that are obese are more likely to develop FSGS because the kidney filters are working over time. So let's talk a little bit about the genetics of kidney disease. So a landmark discovery was made in 2010 to explain why people of African descent are more prone to develop FSGS and other kidney diseases. The group from Harvard and NIH reported that it is due to variation in the gene called APOL1, APOL1, but we call it APOL1. They call the variation that is associated with FSGS and other chronic kidney disease as G1 and G2 variations. They reported that having 2 copies of this variation is associated with FSGS and other kidney diseases. It is now known that about 12 to 15% of people of color carry this variation, compared with almost 0% in white people. So this variation is a risk factor. It doesn't mean that 12 to 15% of people actually have FSGS. It doesn't mean that everybody that has this variation will develop FSGS. But let's put the number in perspective. We know that 1 in 5 people with copies of APOL1 renal risk variant will develop kidney disease over their lifetime, so 20%. We know that this APOL1 variant accounts for 70% of different kidney disease that are not related to diabetes. And we know that if we look at people of color that are on dialysis, 4 of them actually have kidney failure that are actually associated with this APOL1 variant. So it's a big problem in our community, and we have to tackle it head on. So the variation that happened in APOL1 actually happened millions of years ago. It is an adaptation or what I call the mother's nature way to protect against severe sleeping sickness, otherwise called trypanosomiasis. This is a condition that used to cause a lot of deaths in Africa many years ago. Unfortunately, the same variant that protects against sleeping sickness can increase the risk of kidney disease. It is important to always remember this story so as to remove any sense of guilt. In other words, what I'm saying is, it is not your fault. This discovery, however, clearly delineates the power of research, because for people with kidney disease that are associated with ApoL1, there is light at the end of the dark tunnel. Multiple investigators in partnership with bioindustries are now trying to identify medications that can treat kidney diseases associated with defects in ApoL1. There is no doubt, I have no doubt in my mind that this is going to be a big game changer moving forward. So this is another slide that is actually showing that ApoL1 variants can also lead to high blood pressure. This is a study that was done by my very good friend, Rasheed. So let's go to the next slide now, which is very, very important for people living with FSGS and those of us looking after them. How is FSGS treated? So currently, we use steroids and other classes of immune suppressing medication to treat FSGS. However, these medications are probably effective. And when I say these medications, combinations of the medications are probably effective in only about 30% of the patients. So also, these medications are not specific and they all have major side effects. So the bottom line is that we need specific and non-toxic treatment. Currently, what we do is we give some medication to reduce protein in the urine, because we know that if we reduce protein in the urine, we actually reduce inflammation. And when we reduce inflammation, that will reduce scarring and progressive damage to the kidney. And the class of medication that we use commonly now are medication called ACE inhibitor or angiotensin receptor blockers. But again, they are not cure, and we should continue to find a cure for nephrotic syndrome, FSGS, and other diseases of the kidney filters. Okay, as severe as this condition is, what I would like to tell people in this forum today is, know that you are not alone in this. Your caregivers, the policymakers, biopharmaceutical industries, and non-governmental organizations are working day and night to make sure that we find a durable cure, a durable, effective, non-toxic cure for this condition. So what I will now do in the next slides are actually to discuss briefly how all stakeholders are doing this. So when people talk about clinical studies and clinical trial, these are research studies involving people. So the goals are to find new treatments that are safe and effective, because we are going to be trying new agents in human beings. You don't just take the medication and start giving it to people. You have to show that the medication is safe. You have to find the dose that is safe, for the dose of the medication that is safe. You have to show that this medication is better than what we have now. And that is why clinical trials generally are divided into 3 phases. So we have the phase 1, where you actually give the medication to a very small group of people. And the aim of this phase is actually to look at possible side effects of the medication. Once we do that, and we're happy that the side effects are minimal, we then go to what we call the phase 2 trial. What we are doing in phase 2 trial is, if we give this medication, does it actually make difference to this disease? Does the treatment work? So when you are doing that, you actually give the medication to more people. You are trying to find the best dose, and you're actually trying to gather additional safety information to make sure that the medication has minimal side effects. Once you've passed phase 2, you then go to phase 3, and what you are doing here is actually comparing your new treatment with current treatments that are available, or you are comparing your treatment with placebo. you do this on a larger population of patients, and this will further evaluate the effectiveness of this medication and the safety of this medication in the treatment of the condition that you are targeting. In our case here, FSGS. So prior to 10 to 20 years ago, there are few clinical trials in this field, but with the attention that different non-governmental organizations, the famous people that I've talked about earlier on, with what they are doing, awareness, they're increasing awareness, and there are now multiple clinical trials trying to find a durable cure for FSGS. So this is a snapshot from the website of Nephrotic Kidney International, and I will encourage all of you to actually visit the website to see ongoing trials that you can participate in. In addition, you should also go to clinicaltrials.gov to actually look at ongoing trials. Now, let me talk briefly about one ongoing trial now, which is the trial of Duplex, the trial called Duplex, and it is the study of a medication called sparsentan in the treatment of FSGS. This clinical trial will determine the effectiveness of sparsentan at reducing proteinuria in patients with primary FSGS. And the goal of the study is to determine if sparsentan works better than irbesartan at reducing proteinuria and reducing the rate of kidney damage caused by FSGS. I will talk about the differences between sparsentan and irbesartan shortly. So what is involved for the patient? Eligible participant will need to visit the study location about 17 times over a course of 2 years. There will also be times when they will need to speak by telephone to study team personnel at the study location, and the study will take about 2 years plus. Right. So sparsentan is actually work on 2 receptors that may lead to progression of kidney disease, whereas the medication that we are comparing it with, irbesartan, actually works on only 1 receptor. So this is what is actually illustrated in this diagram here. So if you look at this, sparsentan work on a receptor that we call endothelin receptor and angiotensin receptor. On the other hand, irbesartan actually work on only angiotensin receptor, and irbesartan is similar to medications that we actually use now, like lisinopril and losartan. So sparsentan blocks 2 types of receptor on kidney cells at the same time. So this is an overview of the Duplex study. So they've passed phase 1 study, they've passed phase 2 study, so we are now in phase 3 study. And what we are doing is we are comparing sparsentan with irbesartan. So these are capsules that are swallowed. Both drugs are active, so there is no placebo. So the worst that you can be on is actually a replacement of the medication that you're currently on. It's a double-blind study. People in the study and doctors will not know who is taking which treatment until the end of the study. It is a broad-based study because 300 people are going to be involved, and they're going to involve 300 sites worldwide. What this means is that this study will actually generate results that will have broad-based application. Study duration is about 2 years plus, and if you're participating in the study, it may actually require about 18 hospital visits over this period. So sparsentan has the potential to be the first treatment approved specifically for the treatment of FSGS. And like I said, 300 people, 300 clinical centers will be part of the study. So approval will be based on a body of evidence, not just data from a single study. So this is actually the power of the study. So who can participate? In our country, the United States, and also in United Kingdom, people aged 8 to 75 years with a diagnosis of FSGS based on a kidney biopsy, or people that are known to have a genetic issue that can cause FSGS. People will also be selected based on the amount of protein in their urine and based on the level of their kidney function measured by what we call GFR, glomerular filtration rate. Participants will have to be stable for greater than 1 month on medicine that suppress the immune system like prednisolone, and they cannot have been treated with other immunosuppressants like rituximab for 3 months before screening. Because we do not know the effect of this medication on unborn babies. Ladies who are participating, we have to be willing to use contraception if they are of childbearing age. So what does this trial involve? In the first 6 weeks, you and your doctor will answer some questions to see if you are eligible to take part in this trial. If you are eligible, you will be assigned to one of two treatment groups. So you'll either be taking sparsentan, that's the medication that is blocking 2 receptors, or irbesartan, the standard medication that is blocking only 1 receptor. You may need to stop some of your current treatments for 2 weeks before the study starts. So the treatment period is actually 108 weeks, that's 2 years plus. So you'll be given an introductory dose and for both medication. And if you tolerate this introductory dose, you will then start taking the target dose of sparsentan or irbesartan. At the end of the 108 weeks, we will stop the treatment for 4 weeks, and you will be on standard treatment at that time. After the 4 weeks, we'll now go to what we call the open label extension of the study, where all participants will actually be given sparsentan. That's the medication that blocks 2 receptors. Multiple centers are participating in this study. My institution, Duke University, is participating in this study. Our neighbor, University of North Carolina, Chapel Hill, are participating in this study. So people who are tuning in from North Carolina, please get in touch with people in this institution and they will point you in the right direction. So what are we going to learn from the duplex study? So duplex will provide us with important evidence about how sparsentan work in people with FSGS. So the question that we're trying to answer is, can it help to slow declining kidney function? What are the side effects that people can experience if they take this medication? If the results are positive and the side effects are minimal, sparsentan could be the first treatment approved specifically for the treatment of FSGS. And like I said, approval will be based on studying a wide variety of patients. I will encourage people to visit all these websites to learn more about the study. So more importantly, as we are rounding up, the way in which I look at FSGS and other chronic kidney diseases is that we are all in this together and we have to share decision-making with our doctors. You don't just take, go and do this, go and do that. You should ask questions. Starting from your diagnosis, you need to understand your diagnosis. Doctor, what is FSGS? What does it stand for? You should know how to read your lab reports. Yeah, your serum protein is 1.5. What does that mean? What is normal? Your serum creatinine is 1.5. What does that mean? What is normal? These are all valid questions that we should ask. And we should explore all medications and treatment that are available for the disease. You need to arm yourself with information and not ask your doctor about side effects of the medication that you are taking. Clinical studies that are available that you can participate in or that your loved ones can participate in. The importance, ask your doctors about the importance of nutrition and exercise, and make sure that you take ownership of this. Do not allow this condition to define you. Of course, it is a community. We need to rely on advocacy groups and multiple online resources that are available. There are also psychological resources in most of the local areas where we all live. And there are additional patient resources. First of all is the blackhealthmatters.com. This is a wonderful organization that is doing a lot in making our community healthy. I will encourage people to visit their website and learn about all the great work that they're doing. Nepcure Kidney International, Association of people living with kidney disease, and National Kidney Foundation are other websites and other organizations and that we should all reach out to. And with that, I will stop and once more say a big thank you for giving me this opportunity to be part of this discussion, and I'll be willing to take questions. Okay, so we have a number of questions here. Okay, so the first question here says, Are there food or diet that would support healthy kidney functions? This is a very, very important question. We need to eat healthy. What is healthy eating? Let's avoid a lot of salt. Let's avoid a lot of greasy food. Let's drink a lot of water to stay well hydrated. If we do all this will prevent us from developing kidney disease, or will also slow the progression of kidney disease. Okay. How can FSGS be prevented? That's actually related. This is a very interesting question, a very, very interesting question. Can ibuprofen cause kidney issue? So ibuprofen and medication in that class, like Advil, generally doesn't go well with kidney disease. And that's just because this class of medication can actually cause reduced blood flow to the kidney, especially if they are taken for a prolonged period of time. So generally speaking, we actually discourage people from using this. In fact, what I tell my patients in the clinic, if your child should have fever, the first medication that I want you to use is Tylenol. The second medication is Tylenol. The third one is Tylenol. And if this is not working, you need to call me and we figure out what we're going to do next. This is another good question. Do you recommend that African Americans universally get screening for APOL1? This is an ongoing question, and I don't think there's a right or a wrong answer for this. But the way in which I look at it is that universal testing will only become meaningful when we actually have some kind of intervention for this condition. So my own take on this is that for some group of people, testing is actually very important. However, universal testing will only become relevant and useful when we have some kind of cure for this condition. Here is another question. What renal complications do you see from COVID-19 infection? There are a number of reports from New York especially that people who develop COVID-19 infection can actually develop acute kidney injury. And in some patients that have had kidney biopsy done, they've actually seen some variants of FSGS called collapsing FSGS. Now, we do not know whether it is COVID that is causing this directly or it is COVID that is actually making this to flare up. But there's definitely some association between COVID-19 infection and kidney disease that affects the kidney filters. So there's a question with a person with sickle cell anemia, what should they look for? I think the guidelines is actually basically the same thing for people without sickle cell disease. Essentially, what we should look out for is if you notice any swelling, if you notice that you are passing foamy urine, if you notice that you are getting excessively tired, it is actually time to look into this and get in touch with your doctor, get checked out to know exactly what is going on. I think those are all the questions that I've seen so far. Hello? Oh, so there are actually some other questions here. Is eating meat worsen? Does eating meat worsen the condition? Like I said, what we actually promote is healthy eating. Let's be reasonable. Let's avoid greasy food. Let's avoid taking a lot of red meat. Let's take fruits and mixed vegetables. Let's stay well hydrated. There's a question here about metformin. Is long-term use of treatment damaging? I have not come across any literature along that line. I believe that's a diabetic medication. If that's what your doctor recommended, you need to take your medication and get monitored by your doctors from time to time. At what age should screening start? The most important thing is that we should see our doctors from time to time. Here's another question. When will APOL1 genetic testing become the norm? I think I've answered this question. This will become the norm when we have treatment or some kind of intervention to prevent the effect of the APOL1 variant on the kidney, when we have medication that we are sure can actually slow down kidney damage. But for now, there are some selected people that are tested for APOL1. Okay, here's another one. If someone has had hydronephrosis, what precautions should they take going forward? So hydronephrosis means swelling of the kidney. So that's a kidney disease. And the precautions that we should take are actually as highlighted earlier on. APOL1, when and where is APOL1 test offered? Most academic medical centers, we have a way of testing for this if it's indicated. Here is a question from Wendy. Are you more at risk if you are over 60? Yes, as we get older, like different organs in the body, our kidneys get weaker. Yes, so we should take care. And if we notice any symptoms, we should get in touch with our physician. Can you still have kidney failure if you keep your hemoglobin A1C under 7? That is possible. This is for a patient with diabetes. Yes, we should control our blood sugar and do other things to maintain a healthy kidney. Okay, here's another one. I'm going for a CAT scan of my kidney with dye. Should I be concerned? I think you should discuss this with your doctor. Dye that I used for scan, there is some evidence in the literature that it may cause some temporary impairment of kidney function. And what we do with this is that before the scan, they actually give you plenty of fluid. They make sure that you are well hydrated before the scan and also after the scan. But my recommendation will actually be to have an open discussion with your doctor. I think those are all the questions that I have so far. Hello.
Hi, doctor. Those are all the ones that I see as well.
Okay. So I will encourage people to visit the duplex study virtual booth. Am I saying it right, Akil?
Yes, the Retrophin booth, yes.
Exactly. Please visit Retrophin booth so that you can actually learn more about this study and what this medication, what we think this medication is going to do moving forward. With that, I would say a big thank you for giving me this opportunity to be part of this meeting. This is really wonderful. We should be doing this from time to time, and I'll be more than happy to take more questions offline. Thank you very much.
Thank you, Dr. Gbadegesin, and thank you to everyone that joined us today. We hope you learned a little something, and please continue to engage at the conference. Thank you so much.
Thank you.